All right, let's dive right into this explainer where we're going to rigorously walk through every single clinical point of radiographic shunt evaluation, shuntograms, and shunt tapping. Look, if you manage patients with hydrocephalus, you already know that figuring out if a shunt is actually functioning properly or if it urgently needs an intervention is quite literally one of the most high-stakes puzzles in clinical practice. So today, we're breaking down this entire algorithm piece by piece so you've got the complete picture.
We've got a comprehensive roadmap for us today. First, radiographic evaluation modalities. Then, the shuntogram procedure, followed by a breakdown of radionuclear versus X-ray options. After that, we'll hit the strict indications for shunt tapping, and finally wrap up with the physical shunt tapping technique itself.
Okay, starting off with Section 1, Radiographic Evaluation Modalities. This is really your first line of defense. So, the standard shunt series, which is just a plain X-ray series, is designed to rapidly rule out any gross hardware failures. We're talking disconnections, physical breakages, or tip migration. If you've got a standard VP or ventriculoperitoneal shunt, you absolutely need the full picture. That's an AP and lateral skull, a chest X-ray, and an abdominal X-ray just to trace the entire system. And here's a clinical parole you cannot skip. You must always pull the most recent previous X-rays to compare. Subtle breaks are super easy to miss, especially if you're dealing with a complicated system that has multiple ventricular or cyst ends or extra accessory hardware.
Now here's a massive caveat, because anatomy sometimes compensates for hardware failure. Finding a disconnection on an X-ray doesn't automatically mean the CSF flow has stopped completely. Over time, the body actually forms a subcutaneous fibrous tract right around that catheter. So even if the hardware literally separates, CSF can sometimes just keep flowing right through this biological tunnel. That means the patient might actually be totally asymptomatic despite a glaring break on the film. Wild, right?
And while we're hunting for breaks, don't let radiolucent mimics fool you. Not everything that looks like a gap on an X-ray is a broken shunt. For instance, older Halter-style valves have this central silicastic part that just won't show up on a plain film. The exact same thing goes for various connectors, like Y, T, and straight connectors, plus anti-siphon devices and tumor filters. These can appear completely invisible on an X-ray, which perfectly mimics a disconnection. So knowing exactly what hardware is inside your patient is absolutely critical to avoid a false positive.
Moving into cross-sectional imaging, a pediatric patient's anatomy basically dictates your choice here. If you're evaluating an infant with open fontanelles, ultrasound is absolutely your optimal method. It's fast and it completely avoids radiation, especially great if you have a baseline ultrasound to compare it to. But if those fontanelles are closed, a brain CT becomes required to check ventricular size. CTs are also really helpful in complicated cyst-shunt systems, but remember, we always have to balance this against the strict need to minimize radiation exposure in kids.
Sometimes, though, a CT just isn't going to cut it, and you'll need a brain MRI. MRI is hands down the best modality for assessing specific, complex hydrocephalus issues, things like aqueductal stenosis, transependymal absorption of CSF, or loculations. But it comes with a pretty major trade-off. The shunt hardware itself is incredibly hard to see. Plus, and this is a completely non-negotiable safety check, if your patient has a programmable valve, the MRI's magnetic field can actually change its setting. You must evaluate and reprogram those valves immediately after the scan to prevent acute over or under shunting.
And let's not forget the distal end of the whole setup, the abdomen. If you've got a case where undershunting is just totally unexplained by cranial imaging or X-rays, or if you heavily suspect a distal obstruction, you have to look lower. If the patient has abdominal pain, bloating, or signs of acetocyst, an abdominal CT or ultrasound is your immediate next step.
All right, that brings us to Section 2, the shuntogram procedure. This is what we do when basic imaging just doesn't give us the answers.
To be clear, you only escalate to a shuntogram when every other radiographic method we just talked about leaves you hanging. It's a more invasive test, so it's strictly reserved for when shunt function simply cannot be reliably confirmed any other way.
Now, prepping for this procedure has to be incredibly methodical to prevent complications. Step 1, you clip the hair directly over the reservoir. Step 2, thoroughly prep the area, usually with betadine, to maintain strict sterility. Step 3, with the patient lying supine, you carefully tap the shunt by inserting a 25-gauge butterfly needle right into the reservoir. And Step 4, immediately upon entry, you measure the opening pressure with a manometer. Oh, and a quick note for complex cases. If there are multiple ventricular catheters, every single one of them needs to be injected independently to verify its specific patency.
Moving to Section 3, radionucleo versus X-ray. Let's break down the two specific flavors of shuntograms.
The core difference here boils down to the material you're injecting. A radionuclear shuntogram is a nuclear medicine study. You're using radioisotopes, specifically something like 1 millicurie of 99M technetium protactinium. On the flip side, an X-ray shuntogram relies on iodanded contrast. For that, you'd inject an agent like iohexol, which you probably know as Omnipac 180, and follow it up with standard radiography.
Let's look closely at the protocol for the radionuclide injection. Once you've successfully tapped the reservoir, you first drain 2 to 3 milliliters of CSF, always making sure to send 1 milliliter off for culture and sensitivity. Then you inject the radioisotope, again, usually 1 millici of technetium, though 0.5 to 3 is the usable range, mixed in 1 cc of fluid. Now here's the absolute most critical mechanical step. You must occlude the distal flow by compressing the valve or the ports while you inject. This is what ensures the isotope actually goes where you need it to. Finally, you just flush the isotope in using the remaining CSF you drew earlier.
Immediately after that injection, you bring in the gamma camera to track the isotope, and you're targeting 3 very specific areas. First, the abdomen. You image this instantly just to confirm you didn't accidentally inject straight into the distal tubing. Next, the cranium. You want to see the isotope diffusing upwards into the ventricles, because that verifies your proximal catheter is actually patent. And third, you image the distal catheter tip down in the abdomen to rule out any localized pooling that would signal a pseudocyst is forming.
When it comes to interpreting this, it's all about the timing. If you get spontaneous flow into the abdomen within 20 minutes, great, the shunt is patent. If you see absolutely no flow on delayed imaging, the shunt is occluded. At that point, you can try pumping the valve to check for diffusion, just to make sure a pseudocyst isn't trapping the fluid. But if the flow takes longer than 20 minutes, or if the patient literally has to stand up to get gravity to do the work, the study is clinically indeterminate. You can't rely on it alone, you have to use the rest of your clinical picture to decide on a surgical revision.
Okay, we've exhaustively covered imaging, but what if the issue isn't just diagnostic? What if we actually need to physically intervene, clear an obstruction, or get direct fluid samples for a really sick patient?
That takes us to Section 4, Indications for Shunt Tapping, knowing exactly when to physically intervene.
Look, every single time you breach that shunt system, you introduce an infection risk, so it's never something you do lightly. The source material neatly categorizes the valid clinical indications into these 5 distinct pillars: getting a CSF specimen, evaluating function, using it as a temporary rescue for a distally occluded shunt, injecting medication directly into the CNS, and managing tumor cyst catheters. Let's dig into these a bit more.
Focusing on the first 2 pillars, you'll very commonly tap to get CSF to check for a shunt infection, or you might need it for cytology, like if you're screening for malignant cells in a patient with a primitive neuroectodermal tumor, or PET. Sometimes you even tap just to physically clear out blood after an intraventricular hemorrhage. On the function side of things, tapping lets you directly measure those opening pressures we talked about and precisely control your proximal or distal injections of contrast.
For the final indications, tapping gives you direct, targeted delivery of medications, completely bypassing the blood-brain barrier. We're talking antibiotics for severe ventriculitis, or chemotherapeutic anti-neoplastic agents. And finally, for tumor cyst catheters, which, by the way, the text points out are not true shunts, access is crucial. You need it to periodically drain accumulated fluid to relieve pressure or to inject ablative radioactive liquids like phosphorus straight into the cyst cavity.
And finally, Section 5, the shunt tapping technique itself. It's a strict, unforgiving protocol. You really have to follow this point by point if you want to keep complication rates at an absolute minimum. First, shave the area directly over the access point. Second, prep aggressively. The standard is povidone iodine solution, and you leave it for a full 5 minutes for maximum antimicrobial action. Third, always use a 25-gauge butterfly needle or smaller. Fourth, ideally go with a non-coring needle so you don't chew up the silicone port. And fifth, never guess. Only ever introduce that needle into components the manufacturer has specifically designed to be tapped.
And if your goal is specifically to measure pressures, your setup has to be flawless before you even think about breaking the skin. You need that 25-gauge butterfly needle, a full LP tray with a manometer, specimen tubes for your fluid, and a 3-way stopcock ready to direct the flow. It's a highly physical, incredibly meticulous protocol. Which actually leaves us with a pretty provocative thought to wrap up on. Considering the massive inherent infection risks every time we break into the system. As modern imaging and telemetric sensor technologies evolve, will non-invasive pressure monitoring ever fully replace the need for these physical taps? Definitely something to chew on. Thanks for joining this explainer, and we will see you next time.